Hello everyone, my name is Josh Subielka. Today I'm going to be talking about patient expectations. I'd like to thank the Duke Center of Excellence in Manual and Manipulative Therapy for allowing me to speak on this topic today. So the objectives for today are going to be to identify gaps in the current literature, recognize what expectations we discovered patients hold when seeking care for a musculoskeletal evaluation, and then relate our identified expectations to clinical practice. Some background, there's not a ton of research, and at least really good quality, open-ended qualitative research for what patients expect for PT evaluations, subsequent treatment sessions, and then ultimately at discharge and conclusion of care. The research that we do have tends to limit open-ended responses in favor of closed-ended survey questions and Likert scales. The evidence that we do have on the topic also shows that expectations help to predict things like outcomes, cost, satisfaction when seeking care. And then we know that positive expectations tend to lead toward more positive outcomes, and negative expectations tend to lead to more negative or poorer outcomes. We have high expectations that patients have reported for strengthening and stretching, massage and manipulation, and aerobic training, neutral expectations for things like modalities and traction, and then low expectations for medication and surgery. So we should be leveraging these things in the physical therapy world because they have high expectations for things that we do on a regular daily basis and low expectations for much more invasive procedures. Patients also report that it's likely that PTs are going to help them improve their physical activity levels, improve their physical fitness, and think that it's likely that physical therapists are going to provide things like hot and cold treatment, massage, and taping techniques, with very few of the subjects reporting that they thought it was likely that PTs would provide services like joint manipulation and mobilization, acupuncture, and cupping. So the purpose of our study was to determine what patient expectations were prior to starting care for a musculoskeletal complaint. So we did a qualitative analysis of 25 subjects prior to their initial appointment. Our inclusion was that they were at least 18 years old and seeking care for musculoskeletal pathology. We based our research off of Louis Gifford's 4 questions that he postulated that all patients wanted to know about in his book, Aches and Pains. And those were, what's wrong with me? How long is it going to take for me to get better? What can I as the patient do to improve my symptoms? And then what can you as the provider do to help improve my symptoms? We identified 23 total themes from our interviews, with our top themes being outcomes, education, exercise, evaluation, and cause of pain. And there was a lot of overlap amongst these conditions, which we'll talk about. So outcomes really centered around pain alleviation and addressing the fear of ongoing persistence of pain. And they wanted to do that by addressing correcting movement patterns, improving posture, and then continuing a home exercise program once they were finished with PT. So they thought all those things would help ultimately improve their outcomes. Patients also wanted to learn. So they wanted education on what physical therapy and that particular provider is going to be able to do for them, proper exercise performance, what types of things are wrong, whether it's movement patterns, whether it's tissue issues, things like that, and then to teach them what types of self-management strategies they can have for long-term effectiveness. They wanted to learn more exercise, engage in proper technique, understand what exercises were going to be the most beneficial for their long-term recovery, and then how to manage those symptoms long-term. They also expected evaluation at that initial point with measurements, and then those measurements to be followed up at subsequent treatment sessions and ultimately performed again at discharge to understand where they started, where they finished, and then guide any additional recommendations that the physical therapist may have at the conclusion of care, if they recommended any additional medical procedures like injections or surgery, or if they were good with their home exercise program alone. And then they also wanted to know the cause of their pain. So 10 of our subjects of the 25 already felt like they had a diagnosis, and then 14 wanted to know the cause of their symptoms or get a diagnosis. And obviously we understand that this can sometimes be really challenging, as it's very difficult sometimes to pinpoint a specific tissue issue. The interesting thing that we did find, or did not find rather, was that only 9 subjects mentioned manual therapy, and the emphasis was on general manipulation, not necessarily joint high velocity, low amplitude manipulation, but just general manipulation and massage. So that wasn't something that people tended to bring up, which we thought was really interesting. We also propose a 5th question, and that is, what is the expected outcome of physical therapy for that patient in that provider? Because we know that if patient expectations don't match the provider expectations, satisfaction with care tends to go down. So clinicians should really work to understand patient expectations and then work within those expectations or modulate some of those expectations and set up realistic goals and expectations for the conclusion of care in order to optimize satisfaction. So we found that patients did want answers to Louis Gifford's 4 questions. Clinicians should work to answer some of those things with those key themes that we identified at the time of the initial evaluation, and then continue those things in subsequent treatment sessions, as well as address that 5th question of what's the expected outcome of physical therapy. If anybody would like to contact me, there's my email, in addition to it being in our paper. That was on the first slide. And then I'd like to acknowledge Bell & Health. Special thanks to them for helping us conduct our research, and then to my co-authors, Kristen Smith and Joe Signorino, and our research advisors, Jody Young, Dan Rowan, and Casey Rentmeester.